So Medicare spends about a third of its budget annually on inpatient hospitalizations. And of those hospitalizations, about 40% are for the same diagnosis over and over again, CHF. An expensive diagnosis when somebody's in the hospital, and expensive when they get readmitted, which they tend to at a very high rate. And the reason this happens is that the treatment for CHF is largely diet and medical. Beta blockers and ACE inhibitors, diuretics, things like that. And as we know, adherence is very poor. It's been documented through all age groups, from teenagers with diabetes and asthma, things like that, to middle-aged people with hypertension, dyslipidemia, cholesterol, things. And in this population, it's particularly poor. Why? Well, think about what happens in the hospital, particularly somebody with acute CHF or cardiac shock. They're sent to the emergency room, they get put up in the ICU, and if you've ever been in an ICU, you see somebody with a million lines and a breathing tube and telemetry monitors and all this wonderful technology that we have in the system, and then we send them home like this. And we say, here's your medicines, good luck. So it's no wonder that these people who are on average at least 9 or 10 medicines have a hard time being compliant, and we think that there is opportunity there to change the rules of the game somewhat. And I'm happy to say, as a doctor who practiced many years, it's great to see that there's a lot of effort being spent in this area. Numerous is, another company, Out Janssen, has a product similar in the adherence area worth looking at. We have a slightly different approach, and what I'm going to be presenting here is not really our adherence app per se, but our transitional care platform, because so much, as we saw, of readmissions are related to medication adherence. So what we tried to do is use the lessons that we learned with our developing our app and take it into a tablet-based coordinated care platform. Now that the ACA has been held, hospitals are at risk for repeated admissions, what Medicare calls avoidable or expendable admissions. And this is based on a formula. If a hospital exceeds that formula on admissions, they will get dinged. So they're implementing programs such as coordinated care programs with nurses who call the patients and visiting nurses to make sure that people are taking care of themselves and weighing themselves and things like that. These are very expensive. We can augment these programs and make them much more efficient by having a transitional care accessory, if you will, that goes home with the patient and then educates them and keeps them on track with what they're supposed to be doing. Now, particularly in the elderly, there's a great resistance to technology. I was just telling somebody a few minutes ago how I was at the airport on Monday, and the clerk behind the counter said to the elderly lady behind me, "Ma'am, you can use the kiosk." And she said, "Oh, I can't. I'm afraid of that." The problem was not with the technology, the problem was with the user interface, because it appeared unapproachable. So that's what we tried to do with our product, counter that fear, make it approachable, make it somewhat whimsical, and build in a reward system unlike any other. I won't really get into that, maybe there'll be time for a question or two, but we use some very novel incentive methodology. When the user gets the platform, all their medicines and their appointments will be automatically loaded from the EHR. They can see exactly what medicine they're supposed to take when, with an image of that medicine, and interact with it. When they take it, it'll go back to the server. We're also developing at my company a unit dose delivery device that goes onto phones. I won't talk about that now. It's called MedWheel, and it's on our website. That would certainly reduce medication errors, eliminate all those amber bottles that people go home with. It would be medicine just prepackaged daily. The other things that we can use on a smart platform is make use of all the great functionalities these tablets have. We can put incentives behind what we call our scratch game here. It's a virtual scratch game to build in a little bit more suspense and engagement for the user. And behind that, working with loyalty programs, we can provide offers and other incentives that are really targeted just to that user. So it really speaks to them, their experience, and their shopping behavior. As I say, I'd be happy to answer more questions about that. We can also integrate with devices, Bluetooth and other connectivity devices such as scales or blood pressure cuffs, so this information can then populate the medical record. We can find out how the patient is feeling that day, again, in a very icon-driven and cross-cultural platform, such that it's very easy for even the most inexperienced technology user to be able to function with it. And ask them what symptoms they have. As you see, leg swelling for patients with CHF. We can build in tap to conference functionality so the user can speak to the caregivers. And we can also build in voice recognition technology so that both sides can see what the conversation entailed, they can approve that it's accurate, and that can again be used as a reference. All of these features we offer to our potential clients, those that being payers and health systems, for them to choose which functionality they would like to build into the platform. This is a picture that the user can send back to the caregivers. They can put in their activity level, and we can link with devices such as Fitbit and such to see that people are getting the appropriate exercise. We can also integrate with wireless barometry things, help them with their diet. And this is very important because this is one of the biggest issues my primary care colleagues tell me when people are discharged from the hospital. They have appointments with numerous physicians typically, and it gets lost in the system, and none of the physicians know who else is seeing the patient. We can bring it all together here on a tablet at a very low cost with software cost per unit at just a few $100s, far less than the cost of human-based coordinated care systems. Again, I don't think that we will replace them, but I think we can certainly augment those programs and make them function much better. I'll just show my last slide here. This is an example on the dashboard of what the caregiver may see, which patients are falling out of compliance and such, and the issues can be addressed. I have about 2 minutes if anybody has a question. Seeing none, thank you very much.